Let's discuss some high-yield concepts about cirrhosis for your NBME internal medicine exam and USMLE Step 2 exam. Here's a case of a 40-year-old man presents to the emergency department with increasing abdominal distension and discomfort over the past 2 weeks. He has a history of cirrhosis secondary to chronic alcohol use. He denies fever, vomiting, or changes in bowel habits. On physical exam, his abdomen is distended with a positive fluid wave and shifting dullness. He also has scleral icterus and spider angiomata. But before we dive into this case further, let's just first step back for a second and talk about cirrhosis. So, how do you define cirrhosis? And specifically, how do you define decompensated cirrhosis? Cirrhosis is the 12th most common cause of death worldwide and the 8th highest cost to treat illness worldwide. Cirrhosis is both pathological and clinical diagnosis. Pathologically, it is characterized by the histological disruption of the liver's architecture due to the fibrous replacement of normal liver tissue. This process leads to portal hypertension and end-stage liver disease, which is usually irreversible in its advanced stage. Yes or no? Clinically, are we good at identifying patients with cirrhosis before they develop findings related to end stage liver disease? Unfortunately, the answer is no. Clinically, a patient is typically diagnosed with cirrhosis when they present with decompensation or clinical decline, which can manifest as esophageal variceal bleeding, renal failure, spontaneous bacterial peritonitis, hepatic encephalopathy, or ascites. Early recognition and diagnosis of decompensated cirrhosis are crucial due to its high mortality without a transplant, with a 2 year mortality rate reaching up to 26.4% and a 5 year mortality rate as high as 85%. For patients with high suspicion of liver disease, lab tests to assess liver injury should be ordered. These tests include a CBC, AST, ALT, albumin, alkaline phosphatase, GGT, total bilirubin, prothrombin time, and INR. The American College of Gastroenterology recommends that if aminotransferases are elevated during routine blood tests, additional lab tests is required. This includes hepatitis B surface antigen, hepatitis B core antibody, hepatitis B surface antibody, hepatitis C virus antibodies, and iron studies. Abdominal ultrasound should also be ordered in order to rule out an acute or structural disease process. Liver biopsy is the diagnostic test for cirrhosis. However, this is invasive. There are non invasive testing, especially transient elastography, as the preferred test in evaluation of liver fibrosis instead of liver biopsy. Transient elastography determines liver stiffness by measuring the velocity of low frequency ultrasound waves traveling through the liver, and this is a non invasive procedure. Once patients develop cirrhosis, are they mostly asymptomatic or symptomatic? Cirrhosis is frequently clinically asymptomatic and progresses insidiously in its early stages. Typically, a patient may do well for a decade or longer before the development of decompensation, which marks the end stage of cirrhosis. At this stage, patients will develop significant manifestations of liver failure and portal hypertension, including ascites, hepatic encephalopathy, and variceal hemorrhage as major manifestations, along with jaundice, which reflects impaired bilirubin clearance. This progression to decompensated cirrhosis may occur over 10 years, but depends, of course, on various factors. There are two stages of cirrhosis: compensated cirrhosis and decompensated cirrhosis. Compensated cirrhosis is a patient that may not look or feel very sick. Symptoms may include generalized weakness, poor appetite, and weight loss. The median survival of patients with compensated cirrhosis is at least 12 years. Decompensated cirrhosis is the symptomatic stage, and the median survival time is only 2 years. Patients may present with jaundice, ascites, hepatic encephalopathy, and esophageal variceal bleed. Upon the development of complications related to cirrhosis, the patient enters the decompensated phase of cirrhosis, which has poor projected outcomes. Appropriate management of these complications is vital to ensure optimal patient comfort and better quality of life. An easy way to remember the main complications is through the acronym VIBES. Simply, it is an acronym that stands for V for volume, I for infection, B for bleeding, E for encephalopathy, and S for screening. First, let's talk about volume. In end-stage liver disease, ascites is the most frequently encountered complication. Ascites is defined as the presence of excessive fluid in the peritoneal cavity. The pathophysiology is based on the onset of portal hypertension, which then leads to splanchnic vasodilation, the ensuing activation of the renin-angiotensin-aldosterone system, and finally resulting in retention of sodium. This results in the classic signs of symptoms of abdominal distension, nausea and vomiting, early satiety, shortness of breath, and reduced mobility. A 52-year-old man presents to your clinic with increasing abdominal distension and discomfort over the past few weeks. He has a history of chronic alcohol use and was diagnosed with cirrhosis 3 years ago. On physical exam, he has a distended abdomen with a positive fluid wave test indicating that the patient has ascites. Lab studies revealed the following: a serum albumin of 2.5, acidic fluid albumin of 0.7. What is the next best step in evaluating the cause of this patient's ascites? Order a liver biopsy, calculate the serum ascites albumin gradient or SAG, order a hepatitis panel, order a CT scan of the abdomen. The correct answer in this case is B. Calculate the serum ascites albumin gradient or SAG. When the patient presents with ascites, the next step in evaluation should be a diagnostic paracentesis. During this procedure, it is important to check the serum ascites albumin gradient to determine if the ascites is due to cirrhosis. The serum ascites albumin gradient or SAG is measured by subtracting the level of albumin in the acidic fluid from the serum albumin measurement. A high gradient of more than 1.1 grams per deciliter indicates portal hypertension. A low gradient with a SAG of less than 1.1 grams per deciliter indicates a non-portal hypertension and suggests a peritoneal cause of ascites. Total protein levels in acidic fluid also help determine the cause of the ascites. A total fluid protein of more than 2.5 grams per deciliter suggests a cardiac etiology like heart failure. A 60-year-old female with a history of hepatitis C presents to the emergency department with abdominal distension and discomfort. On exam, she has a distended abdomen with shifting dullness suggestive of ascites. Therefore, we perform the paracentesis, and the acidic fluid analysis reveals an albumin concentration of 1.0. Her serum albumin level is 3.0. What is the most likely underlying cause of her ascites? Is it nephrotic syndrome, malignancy, pancreatitis, portal hypertension, or tuberculosis? The correct answer is D, portal hypertension. The serum ascites albumin gradient, SAG, is calculated by subtracting the acidic fluid albumin concentration from the serum albumin concentration. In this case, the SAG is calculated. SAG equals 3.0 minus 1.0, which is equal to 2.0 grams per deciliter. A SAG of 2.0 suggests that portal hypertension is the most likely cause of the patient's ascites. A 65-year-old man with a history of hypertension and CAD presents to the clinic with increasing abdominal distension and shortness of breath over the past month. On exam, He has jugular venous distension, bilateral lower extremity edema, and a positive fluid wave test indicating ascites. Lab studies revealed the following: serum albumin 3.2, acidic fluid albumin 1.5, acidic fluid total protein of 3.0. What is the most likely underlying cause of his ascites? Cirrhosis, nephrotic syndrome, heart failure, or pancreatitis? The correct answer is C, heart failure. The SAG is calculated to determine if the ascites is due to portal hypertension, with a SAG of 1.1 suggesting portal hypertension. In this case, SAG equals 3.2 minus 1.5, which is equivalent to 1.7 grams per deciliter. A SAG of more than 1.1 indicates that portal hypertension is likely involved, such as this case. However, the total protein concentration in the acidic fluid helps differentiate the cause. Acidic fluid total protein of more than 2.5 grams per deciliter suggests a cardiac cause like heart failure, whereas the lower levels are more typical of liver cirrhosis. In this patient, the acidic fluid total protein is 3.0, which combined with a SAG of 1.7 strongly suggests a cardiac cause like heart failure as the underlying cause of the patient's ascites. The recommended treatment for ascites ultimately depends on the individual patient's needs. The first line of therapy is sodium restriction of 2 grams of sodium per day. Depending on the severity, the limit may become more stringent. For example, those with refractory ascites may require to limit their sodium intake to even less than 500 milligrams per day. Diuretics are the mainstay of treatment for ascites, with the RAS system being the primary target for diuresis. Spironolactone is the initial diuretic of choice in cirrhosis, as it directly inhibits RAS activation. If additional diuresis is needed, furosemide can be added to help maintain potassium balance. The recommended ratio to achieve this balance is 100 milligrams of spironolactone to 40 milligrams of furosemide, with maximum doses of 400 milligrams and 160 milligrams, respectively. Now let's talk about I for infection. Yes or no? Is bacterial infection more prevalent in patients with cirrhosis than in the general population? The correct answer is yes. Bacterial infections are more prevalent in patients with cirrhosis than in the general population. This increased prevalence is hypothesized to be due to depressed immune systems and bacterial translocation from the gut to the bloodstream. Spontaneous bacterial peritonitis, in short SBP, virtually always occurs in patients with cirrhosis and ascites and is expected when the patient presents with abdominal pain, fever, or altered mental status. There are no diagnostic criteria for SBP, and a minority of patients also presents without abdominal pain. The majority of the isolated organisms in SBP are gram-negative enteric organisms like E. coli and Klebsiella pneumoniae, which suggests that the primary source of contamination is the GI tract. One should have a high index of suspicion for SBP in all patients presenting with ascites, and this is especially true if the patient has an acute history of clinical deterioration. SBP must be ruled out by a diagnostic paracentesis in all patients who present with ascites. A diagnosis of SBP is made if the polymorphonuclear cells neutrophils count in the acidic fluid is more than 250. Once diagnosed, it should be treated with third-generation cephalosporins for 5 to 7 days, such as cefoxitisime and ceftriaxone. What about antibiotic prophylaxis against SBP? We recommend antibiotic prophylaxis for patients at high risk of developing spontaneous bacterial peritonitis rather than waiting for SBP to develop before starting an antibiotic therapy. In these high risk patients, antibiotic prophylaxis is associated with a decreased risk of bacterial infection and even mortality. We administer antibiotic prophylaxis as a daily routine medication. Patients at high risk for SBP includes the following: patients with cirrhosis and GI bleeding, and patients who have had at least one or more episodes of SBP. Antibiotics for SBP prophylaxis includes trimethoprim, sulfamethoxazole, which is Bactrim, ciprofloxacin, and norfloxacin. B is for bleeding. B stands for bleeding. One of the most important and fatal complications of cirrhosis is the rupture of the gastroesophageal varices secondary to portal hypertension. Increased portal pressures cause a backup of blood flow into the collateral tracts, including the esophageal azygous venous system, leading to the distension of the esophageal veins. This results in the formation of esophageal varices, which, when severe and large enough, can rupture spontaneously, leading to a life-threatening hemorrhage. For acute esophageal variceal upper GI bleed, we first have to stabilize the patient and secure the airway. Early EGD is recommended. For non-variceal GI bleed, EGD is recommended within 24 hours, but since variceal bleed has a high mortality, EGD is actually recommended within 12 hours of presentation. The most effective way to control an esophageal variceal upper GI bleed is endoscopic therapy combined with this medication. Can you think of a vasoactive agent that we order to control the upper GI bleed? One vasoactive agent is called octreotide. Octreotide reduces portal hypertension by providing splanchnic vasoconstriction. PPIs can be administered in conjunction with treatments for the bleeding, and the value of antibiotics during an acute bleed has been well demonstrated. We should also provide SBP prophylaxis in these situations, as patients with variceal bleeds are at high risk for developing SBP. The recommended prophylaxis is IV ceftriaxone for no more than 7 days. Once a patient has experienced and recovered from an acute variceal bleed, secondary prevention with non-selective beta blockers such as propranolol, carvedilol, and nadolol should be considered. The target resting heart rate for these medications should be between 55 and 60 beats per minute. E is for encephalopathy. Hepatic encephalopathy is due to portosystemic shunting of blood caused by portal hypertension. This is a clinical diagnosis, and checking ammonia level is not necessary to confirm this diagnosis. Administration of the non-absorbed disaccharide lactulose decreases the absorption of nitrogenous substances, leading to improvement in most patients with hepatic encephalopathy. If the response to lactulose therapy is suboptimal, rifaximin can be added to alter the bacterial flora in the intestines. Although rifaximin is better tolerated than lactulose, it is often not used as first-line therapy due to its high cost. S is for screening. Hepatocellular carcinoma is the most common liver tumor in patients with cirrhosis. Patients with cirrhosis from any cause should be screened for HCC. The recommendation is to order abdominal ultrasound with or without alpha fetoprotein every 6 months. This approach leads to early diagnosis, increased rate of curative treatment, and improved 3-year survival rates. Now let's go over some rapid fire concepts on cirrhosis. There are 2 stages of cirrhosis: decompensated cirrhosis and compensated cirrhosis. VIBES is a good acronym to remember the complications related to cirrhosis. Be comfortable calculating SAG for ascites before you take your exam. And remember, a SAG gradient of more than 1.1 indicates portal hypertension, while a SAG gradient of less than 1.1 indicates a non-portal hypertension, such as peritoneal disease. An acidic protein level of more than 2.5 suggests heart failure as the cause of the ascites. Diuretics are the mainstay of ascites management, and this includes spironolactone and furosemide. A neutrophil count in the acidic fluid of more than 250 is diagnostic for SBP. Treatment for SBP is third generation cephalosporins like ceftriaxone. Consider SBP prophylaxis in patients with cirrhosis and GI bleed, or those with at least one episode of SBP. Antibiotics prophylaxis includes trimethoprim sulfamethoxazole, which is Bactrim, ciprofloxacin, and norfloxacin. EGD should be performed within 12 hours if there is an esophageal, variceal, upper GI bleed. Choose an nucleotide drip when a patient presents with an acute esophageal variceal bleed. Once a patient has experienced and recovered from an acute variceal bleed, secondary prevention with a non-selective beta blocker like carvedilol, propranolol, or natalol should be considered with a heart rate goal between 55 and 60 beats per minute. Measuring ammonia level is not necessary to confirm a diagnosis of hepatic encephalopathy, as this is a clinical diagnosis. Initial treatment for hepatic encephalopathy is lactulose. For recurrent hepatic encephalopathy, consider adding rifaximin to lactulose. ACC screening includes abdominal ultrasound every 6 months with or without alpha fetoprotein testing. Thank you. This ends my talk on high yield concepts on cirrhosis.